Hello and welcome to this episode of The Psychology of Almost Everything. My name is Stuart Grant.
And my name's Peter Thompson.
Tonight we're going to talk about the psychological approach to physical health problems, and I'm delighted that we have with us Elspeth Desert, consultant clinical psychologist, manager of a large team of people, not just psychologists, who help people with physical health problems. Hello, Elspeth.
Hello, and thank you for inviting me.
Elspeth, I wonder if we could start getting into things by just asking you, who is it that you actually direct your services to? Who are the people that are benefiting from the services of you and your team?
So the people that come to our team are people who have a major health problem, which is also causing them psychological distress, and that's meaning that they can't lead the life they want. And so our role is to help unpick the role that their health is having and the impact it's having on their psychological well-being, their social activities, and all of the things that they enjoy and that make them have a purposeful and valued life. So the sorts of people we see might have things like cancers, heart disease, diabetes. We also see a lot of people with what we call persistent symptoms. So those are symptoms that they have from long-standing difficulties that persist and really impact negatively on their enjoyment and pleasure in life, and often is accompanied by anxiety or depression because of the disruption it's causing to them. And so the persistent symptoms service that we run is a relatively new service, started in 2016, and reflects really a move away from what we would call a medical model of management to a much more bio-psychosocial model, accepting that perhaps medicine has a limited role in managing some of these persistent symptoms. So those persistent symptoms we'd include things like complex pain, chronic fatigue, fibromyalgia, and now post-COVID symptoms, where the symptoms are there, they're very distressing, nobody's suggesting that those symptoms aren't real for that person, but the medical management of that is going to be extremely limited and often comes with unwanted consequences for people. So you'll be very aware, reading in the press, about what's called the opioid crisis in America. But we have a significant problem here in the UK, mainly from prescribed medication. So people were prescribed opiates like tramadol and other medications for managing pain. But what we're realising over time is that those have very little benefit for patients, but often have unwanted and unpleasant side effects. But some of them are addictive, and people are quite stuck in using that medication. So a lot of our work is helping people learn different strategies from a psychological, social perspective to manage their pain differently, so those medications can be reduced in their management. So we have a team that includes psychologists, CBT therapists, physiotherapists, occupational therapists, and something we call living well coaches, which are people who help people coach and look at how to improve their life.
Well, that's a very comprehensive answer to it sounds like a very comprehensive service. Peter and I are dinosaurs, of course, and so when we trained, virtually all of our clients obviously came from a mental health background, came with mental health problems. But you were perhaps among the first cohort of people who took some of the psychological treatments for people with mental health problems and applied them to physical health problems. Would I be right in saying that?
Yeah, I think that's very true. And if you look at the training now of clinical psychologists, there's much more of the traditional placements that people used to have in learning disabilities, elderly and mental health are broader than that. And even child placements now, some of those are paediatric specialist placements for children with diabetes or cystic fibrosis. So I think the training of clinical psychologists reflects this understanding that the use of psychology has a much broader remit within the NHS.
Listening to you, it reminds me, of course, that whenever anybody's diagnosed with any physical condition, there's always a psychological consequence.
Yeah, and I think that's true. And a lot of people have conditions where the medical management available is quite limited, but they're still left with a distressing set of symptoms that day to day impact on their life.
Could we be specific? I mean, when you say conditions where the medical management is limited, what do you have in mind?
So if you think about chronic back pain, which is a huge problem in the UK, very significant number of people suffer with chronic back pain, and the medical management of that used to be surgical or injections, and now the evidence is that those have limited value. They also, obviously, surgically, there might be difficulties that come from that, or injections might give a few weeks relief, but it wouldn't be appropriate to continue those. In the past, people had them quite regularly, but we're knowing that that is no longer a really viable model. What we're saying is that people have to think about, how do I manage this long-term condition? This is something now that I need to learn the management skills to improve that. So a good example of that is the boom and bust cycle. So if we think about how people over-exercise and then develop pain symptoms, and then they rest and then they over-exercise, so they come on what we call a boom and bust cycle. And we see that for people with chronic fatigue syndrome, we see it in post-COVID, we see it in people with chronic pain. So it's learning about how to pace yourself, how to develop a different set of skills to manage your condition. And so that's what our persistent symptoms service is doing, is saying to people, you have this condition which needs to be managed. How can we as a team help you develop new skills, new ideas? And we talk about living a valued life alongside having this condition.
It must be very skillful by yourself and your team to deliver that message. I can imagine some people would, well, I'm sure you've come up against this, when people are saying things like, oh, you're just saying it's in my mind, or you're saying I'm making it up, or things like that. You know what I mean?
Yeah, and that's very difficult, because if they've had a diagnosis and they expect a medical treatment for that, then it's very hard for them to think, actually, nobody's going to have a cure for this or a solution. But people have very genuine symptoms. Just because the medical management of them is not going to be successful does not mean at all that they're imagining it. And what we talk about with pain is we often use the analogy of things like people who have traumatic injuries. The first thing they tell us is they didn't experience pain, but they've got obvious physical trauma, so there must have been pain. But at that time, the brain has acted to shut down those signals to get to a place of safety. And then when they are, and they'll often say, as soon as I felt safe or I was being treated by a paramedic, I had enormous amount of pain. So we use that example. They obviously had pain, they've got huge trauma, but the brain is able to change the way it reacts to your pain signals. So it can either turn the volume up or it can turn the volume down. So we talk about how the brain works to change the volume on the pain signals you've got. And at times of stress, often your pain is higher, and at times when you're more relaxed and distracted, your pain can be lower. It's not because you're imagining it, it's because the way the brain is processing those signals.
So presumably too, the treatment or interventions that you and your colleagues provide are tailor-made to individual case histories and stories.
Yeah, so every person who comes to us, we spend quite a lot of time doing a detailed assessment when we look at how it all started. We often look at timelines. We find it really helpful to look at timelines, because when we go back to that biopsychosocial model, we're saying what's happening in your life at the time you developed this, what was the disruption that it's caused to your life, and what are the other things that are happening around you, what's been the reaction of your family, or how has it impacted on your work. So we take a detailed history to understand the context for that person of what this health problem has created for them. And then we look at, so what's it stopped you doing? What's the impact on your goals, your values, your social life, your hobbies? And I appreciate, for many people, it's an enormous impact on them that then leads them often to become quite low in mood because they can't do the things they take pleasure from. So we start to unpick that problem and come to a shared understanding, or psychologists would call it a formulation, of the impact of this disease on their life and how we can then move forward and think about making some progress.
So that sounds to me as if what you're looking at is the impact is much more important than the diagnosis, as it were.
Yes, and I think one of the things we emphasise to people who come to us, because some people might not have a diagnosis, so we also see people with what used to be called medically unexplained symptoms. So they've got a lot of unpleasant, distressing symptoms that nobody can explain. That's not because those symptoms aren't there, but there's no diagnosis that's specific to the symptoms. So we look at trying to think about putting the diagnosis to one side and saying, so what's the impact on your life? What are the things that you would like to be able to do if we could manage these symptoms better? And so that's why we don't have a separate pain service from a chronic fatigue service, from a medically unexplained symptom service, because actually the unifying thing is the impact on that person, both psychologically, socially, and at work. And if we can focus on that, you can often find ways for that person to manage that condition differently and have a much more valued life and a better quality of life, and that's the emphasis of the service.
Could you give us an example of when you say manage things differently, what a person might do in the beginning and what they might do after they've had a consultation with one of your colleagues?
So in our persistent symptom service, they'll have their first assessment, and the majority of patients go to something called a living well group, which is orientated on a psychological model of acceptance and commitment therapy. So this is saying it's accepting that you have this problem. How are we going to commit to improving your quality of life with that? So the sorts of things we start to look at is their average day, how they sleep, all of the things that are impacted, so that we can basically look at how do we work through those problems that are impacting on their life. So we look at things like sleep, we look at things like exercise, we look at very small things that they might think are important, like, cooking or shopping or walking their dog. And we look at what are your goals, what would a better life look like to you, and helping them unpick how we would progress towards moving towards that goal and pacing that, because obviously everybody wants to be better very quickly, but unfortunately it's often quite a slow, steady progress, and that's one of the first things that people have to adapt to.
So I wonder if you could say a bit about irritable bowel syndrome. When you get that kind of a referral, take us through how you might approach that kind of situation.
So the difficulty with that is people have often had lots of invasive procedures done. Every single time they've expected to get a solution or a medical cure. So you're often starting from a point where people are quite low in mood because they've had lots of disappointment on that journey. It's often been 2 or 3 years since they started with the symptoms, and often, as you were asking me earlier about imagining symptoms, people begin to think that people are saying, I'm imagining this, although they have persistent symptoms of irritable bowel. So what we help people think about, yes, that's the diagnosis, but again, it goes back to what's the impact of that on your life, but also the timeline. So we don't find things like pain diaries necessarily very helpful because it makes you focus on the symptom that you're finding distressing. But sometimes it's really useful to do a timeline to say, when are your symptoms at their worst? What else is happening in your life? And often people will realise that there is an association, that they have an overall reactive gut, but actually it's much worse when they're stressed or they eat certain foods. So sometimes doing a timeline that says, what were you doing at the time it's been at its worst? When's it been better? So helping people to see the connections themselves. So there's no question that they have a symptom that is distressing to them, whether it be their gut or eczema, for example. But I often talk to people about what I call their stress barometer. So their gut or their skin or other things might be their stress barometer. So when they notice the symptoms, it's worth thinking, so what's happening in the life at the moment that might be increasing my stress levels? So that's not saying you haven't got an underlying condition, but it's saying we know it can be made worse. So it's a bit like the pain example. Your brain is turning the volume up on your pain or your gut symptoms. And one of the things that's probably a bit of a sidestep from that, but it's a useful analogy I use a lot with patients with fear of recurrence after cancer. So I spend a lot of my working time in cancer. And basically, if you've been somebody who's had a very normal life and suddenly feels quite fit and well, but gets a cancer diagnosis through screening or a simple lump they find, their brain goes into threat mode and says, well, what else could be wrong with me? So if I think about people's symptoms, we've all got symptoms every single day. But once you've had a cancer diagnosis, those symptoms can take on a sinister meaning. And what your brain does is turn the volume up on noticing it. So I often use the idea of a faulty smoke detector and say it's not just the idea of, it's in the toaster and there's flames. Even going to put the toaster on sets off this faulty smoke detector, and that's what your brain's doing. It's constantly doing a surveillance project on your body. And of course, we've all got daily symptoms and we ignore them. But once you've had a cancer diagnosis, those can take on that sinister bit that sets off the threat response.
Elspeth, that was a fascinating analogy about the faulty smoke detector. Please, go on. Tell us a bit more about it.
Okay, so when people talk about that, the first thing that I always do whenever I meet anybody is to normalise their reaction. So I talk about the threat response. I often use an example of how animals behave when they're threatened and the sense of anxiety that creates, and that our behaviours become, dare I say it, a bit irrational. So I often use the rabbit in the road analogy of people running. The rabbit runs around in the middle of the road and doesn't do anything sensible. We're a bit like that when we're threatened and feeling overwhelmed by a diagnosis of a serious condition. So a lot of my time is normalising that and helping people think that this is actually a normal reaction to a very difficult situation I'm in. And then I often talk to people about, yes, it's very normal, but what I also help them think about is it's not very helpful. So it's normal, but it's not helpful. Mm-hmm. So what can we do as a team to develop a helpful response to that? So in no way suggesting it's not realistic that you would feel threatened with a life-changing diagnosis, but what can we do to develop a helpful coping approach to that? So, for example, if I'm seeing a couple who one of the patients has had cancer and their partner's been supporting them, obviously we know that the partner of people who've had cancer also have high levels of distress and feelings of threat. So we often talk to couples together and we talk about the faulty smoke detector, but then we also help sometimes by getting each of them to do a symptom catalogue, and you find that the partner that hasn't had the cancer treatment has also got a lot of somatic symptoms and aches and pains, but they're normal. They're just how they are normally. And what we help the person with the cancer think about, well, that was how I was before I had cancer. So how can I get back to living with what I describe as a noisy body, the normal symptoms of everyday life that we all have? How can I get back to that feeling that those are not sinister, they're not an indicator that I have other health problems ongoing? So we help with things like cognitive behavioural therapy. We help with getting them to do behavioural experiments and checking out with their partner, for example, but also thinking about things that they can do, distraction, things that help them reduce their concentration on their bodily symptoms. And things like distraction, crosswords, many things that we give them as quick techniques and help them stop thinking about the symptoms for a bit. And then what they notice, obviously, is during that time, they haven't noticed those symptoms. If they were worrying symptoms, they wouldn't have just disappeared when they were distracted.
It's so interesting, isn't it? With my neuropsychologist hat on, you can only really focus on one thing at a time.
Absolutely.
So if you distract yourself with some other activity, be it, as you say, crosswords or something else, you're taking your mind off the pain, the worry, anxiety.
I'll just put a little plug in here. Our first 4 podcasts are about crosswords.
So if you don't know how to do them, go back.
But on a more serious note, it's very interesting is what you're saying there, because in some ways, us as patients are being given a double message, aren't we, in a way? Because we're being taught all the time to be vigilant, look for early signs, get in quickly and you'll get better treatment. And the quicker we get hold of cancer, the better it is. And then at the same time, we don't want to become hyper-vigilant and obsess about our symptoms and so on. Do you see what I'm saying? There's a conflict there, isn't there?
There is a conflict, and what we help people think about, though, is that a number of things about that. They are now the most under surveillance team of people because we're having regular checkups with them, and so they come back in the area I work, which is head and neck cancers. They have 6 weekly appointments after their treatment, so they are being seen very regularly. So we say, you're going to be seen regularly, but in the between times, how are we going to help you get back to what we call a new normal? Because it's never going to be normal like it was before. It's going to be a new normal. So how are we going to help you walk that tightrope of surveillance versus being able to get on with a normal life? And I often describe it as a bit of a tightrope.
I'm smiling because of this word normal. And I cannot tell you how many patients I've worked with, when I've asked them how are you feeling today, they said normal, which of course doesn't really tell you. So I suppose I'm going to put you on the spot here. Could you tell the listeners what you mean by normal? I assume it's something to do with it's usual, to be expected.
It's about saying to them, if you think about the things that you used to take pleasure from before you ever had the misfortune to meet our team, then what are the things that you want to get back to doing? What are your values?
So that's normal for them.
Yes, normal for them. So what's normal for you? Because it's very important. Everybody is a different person, and we need to be sure that we're helping people get back to the valued life they want and that they have. What we do find interesting, though, is that after treatment, some people make quite big decisions about life. They might change their job, they might sort of take up a new hobby. So the new normal, as I call it, is what they rebuild after they've had a life-changing illness. And that might be quite different. Sometimes it helps people think some of the things they prioritised before are no longer a priority. And sometimes our therapy work is saying, so what is it that you want to do now that's different than you were doing before? And it's sometimes their mortality is so sort of in their sort of presence that they think, actually, I need to do these things in my life. I was actually realising, looking back, that I wasn't living a valued life. There were things I wasn't doing that I'm now going to go and do.
Diagnosis as a wake-up call.
Yeah, or growth out of trauma, it's sometimes called, isn't it? But also, what we do encourage people is not to make radical changes at that time, because if you look at, making good decisions, it's never good to do them in a sort of knee-jerk reaction to the situation. But it's worth exploring with them where you might want to be in a year and where you want to be in 2 years and so on, and helping them think about the building blocks to building that new normal. And sort of what I sometimes describe psychology in our services, giving the sort of scaffolding around people to help them rebuild that new normal. So it's about giving them the skills, giving them the safe space to talk about things, and then be able to move forward and develop those skills.
I imagine there are listeners out there hearing what you've just said, thinking, this is fascinating. I would like to do that kind of work. Could you tell everybody your kind of journey, how you became what I'm going to call a health psychologist, or was that you're a clinical psychologist, obviously primary, but are you also a health psychologist?
I am also a health psychologist.
Could you tell listeners how, if they want to become a health psychologist, what they have to do?
So my traditional training was as a clinical psychologist, but now you can also join the NHS as health psychologists. So they're all professions that are registered with the Healthcare Professions Council. So my journey was basically to do assistant jobs after I did my first psychology degree, and then go and do my clinical training, and that's through the NHS. They've just increased the number of places, but it's still very competitive to get in. So you need a first degree usually in psychology. Some people go off and get a master's, but I think it's far more important to go out and do some clinical experience, because then that shows you whether that's what you want to do, because it's not for everybody, and it's important to know this is the right path for you. So a lot of teams like us have assistant psychologist jobs that people come after they've done the first degree, and then they get on to their doctorate training with a university. Health psychology is slightly different in that it's often through a master's and then a part 2 that may be through the BPS, the British Psychological Society, or it may be through a taught course. That's a more difficult route, I think, because you're often relying on self-funding, whereas most NHS clinical courses you get paid while you're training. So I think the health psychology is a difficult course. You can also be a counselling psychologist now working in our service. So that's, again, another course with a first degree in psychology and then a master's or doctorate, often taught again at a university. So there's a number of ways into the profession. But I should also emphasise we employ CBT therapists who may have trained through things like talking therapy services and then move into health psychology. So there are a range of ways into our service as a psychological practitioner. And I think that reflects both what we need for our patients, but also ensuring that we have the right skill set for the patients that we see.
And what about teaching? Do you teach general practitioners, for example, about health psychology?
So we do a lot of teaching for both our own students, but also for junior doctors and for doctors in training in general practice. And so, yes, our team offer that training. The other thing that's quite interesting is we've got what we call CBT First Aiders course for nurses, physiotherapists and doctors, which is an introduction to CBT skills, so cognitive behavioural therapy skills, to use in their day-to-day practice. So we're not expecting them to become CBT therapists, but we think the formulation model is quite useful for physios, OTs and doctors in understanding the complexity of patients that come to them.
I'm just going to interrupt you there, because formulation model is quite a technical term. So I wonder if you could just spell it out for the. Not all our listeners are therapists, obviously,
So I
or
think,
even mental health workers. So just tell us what you mean by that.
so I
please.
think I mentioned it earlier. It's about that sort of understanding and assessment and looking at people's whole life
Okay,
in
yeah.
terms of thinking about. But if you went for a cognitive therapy formulation, you'd be looking very much at thinking, feeling, symptoms, thoughts, emotions, and you'd be bringing all of that together to understand. But it's a shared understanding with the patient you're seeing. So basically trying to get a shared understanding of how they've got to where they are and where they want to move forward. Right. And that's not the same as a diagnostic process, which is maybe what happens in medical training.
Because it's reminded me that doctors are taught not to treat the symptom, but to treat the patient who's got the complaint, and it's the patient who has his or her own unique story.
Absolutely, and it's taking that careful history and broadening that out when we're training doctors into thinking a lot of emphasis onto the psychological and the social aspects of that person, not just the symptoms that they're presenting with those the conditions they come with. And we do have a service that works embedded in primary care, and so that's a good opportunity to work in MDTs, because we haven't talked much about multidisciplinary teams. So we have multidisciplinary teams in cancer care, we have them out in primary care. So most psychologists will work into these multidisciplinary teams. So we're sharing skills all the time, sharing discussions about patients to come up with a better understanding of the people we're trying to help and treat.
Elspeth, I want to ask you a bit about chronic fatigue. What's your approach to that? And maybe you've got some stories for us.
Okay, so we see our chronic fatigue patients, again, because it's a persistent symptom service. Chronic fatigue is a persistent symptom, and we see that as part of a condition that people have. Some people come to us with chronic fatigue from a variety of backgrounds, so it could be that they have had treatment like cancer treatment. So the long-term effects of cancer for many people is persistent fatigue. We have people with a diagnosis of chronic fatigue syndrome that's been made by an immunologist or by their GP. We might have people with fibromyalgia, which has symptoms of fatigue. And again, we're moving away from a diagnostic label and saying to people, what is the impact on your life and what does it prevent you doing? Now, we have had some negative press around this as a service because obviously people have got a very genuine presentation that is disrupting their life, and we're trying to look at how we help them move forward and build a life that has a value for them. But I know a lot of people think that if they have a diagnosis of chronic fatigue, that there will hopefully be a medical solution for that, and it's very disappointing and distressing for them when that isn't on offer. So we've moved away from the diagnostic thing to say, how can we help you manage your fatigue, manage the distressing symptoms, the sleep difficulties that you might have, the intolerance of exercise. Some people find it very difficult to deal with bright lights and things. So it's very much a personalised model of care, putting the patient at the centre of that and saying, how does this impact on your life? What can we do to think about unpicking that and getting a solution that you feel works for you in your situation?
But presumably that's a bit of an uphill battle, because by definition there's no energy to engage really with a treatment program. And maybe I was just wondering if some of the patients feel that you're making demands on them which they can't meet.
So this is the other thing about some of our services, is that patients may be referred, have an assessment, try it out and decide it's not for them. But then again, they may return at a future time to come back to the service. So it has to be the right time for that person. The model we've got is quite flexible. It is quite person-centred, so we do offer remote groups. We do offer telephone consultations, because living where we do, it's quite a big geographical patch. So we try to flex to accommodate people's fatigue difficulties. And obviously another challenge that's come recently in a similar thing is the post-COVID difficulties that people have experienced. And some of those people who've been in very, very unwell and been in ITU. Other people have remained in the community but still have persistent symptoms that are causing them distress. But when we look at the profile of patients we have in post-COVID, the biggest symptom presentation is around their fatigue. It's also often around their mood, because anybody who has symptoms of fatigue will eventually become very low in mood because they can't do the things that bring them pleasure. They have no energy for their hobbies. So it becomes a bit of a vicious circle. You have the chronic fatigue, you then develop symptoms of low mood, and the low mood brings with it symptoms of lack of energy, lack of sleep, etc. So it becomes a bit of a vicious circle.
I've got a couple of questions. Firstly, you mentioned groups quite a bit. I take it lots of your work is face-to-face individuals as well, but are the groups supportive? Or
So the groups are, so sometimes people say, I don't want to come to a group just to moan about my symptoms or other people's symptoms. And we're very keen to say, no, it's quite a structured group. We've got a really comprehensive paper manual that we give to people which explains the way that we're going to work in the group. And the other thing is that because we have a mixed group, so in the group you might have people with a whole range of difficulties. They're not there to sort of discuss their difficulties because actually they might have a different presentation. They might have somebody who's post-cancer treatment, we might have somebody who's post-cardiac treatment. So it's a whole mixed group basically based on geography. So people who live locally, and what we find from these groups is we work on different goals and values for that person, but it's still very personalised for them. They find the group really useful because they realise they're not alone in dealing with this situation and that there are many other people there who are also battling with the same problems and also come up with solutions together. We find that they create informal social networks with other people and actually meet outside the group, which again is very positive for them. But it gives them a sort of beginning to get back to some sort of social contact as well, because having these sorts of conditions can be incredibly isolating. And so people find coming to the group good in terms of meeting other people. If somebody lacks the confidence to the group, that's sometimes where our Living Well coach becomes involved and starts some coaching before they come to the group. We also have the group write messages to the following group to say, I was anxious about coming to the group, but actually when I've come it's been very positive. So they send messages to people who are thinking about coming to the group next to say it's been helpful for these reasons. So most of our groups have between 10 to 15 people in, and they find it really helpful, and the feedback from that is very, very positive.
You mentioned earlier Living Where We Do, just for the sake of the listeners, that we are in Cumbria as we speak, so we're talking about a service presumably around the Carlisle area.
Well, we cover a huge area from sort of Millham on the coast right across to Carlisle and then down to Appleby and Kendal. So it's a huge geographical patch. So we run about 10 groups a week in different areas, which are accessible by bus and for people in wheelchairs and so on. So we try to make it very accessible to people.
Excellent.
can I just ask, this might be our final question in fact, as we're running out of time, unfortunately. What's your impression about your, for want of a better word, success rate?
So,
I take it, given the way that your team has expanded over the years, people obviously value it very much, but what's your overall feeling about this approach to physical health problems?
So the majority of patients give us really positive feedback, even those who perhaps come with a degree of scepticism about whether it's going to be helpful. And that's why would you not be sceptical? Because you've perhaps been on a very long medical journey and then people suggest something different to you. But we also use patient outcome measures, and we use the same ones as the talking therapies on depression and anxiety. And what we're finding is that those scores initially for people with anxiety can go up, because they find the whole process of engaging in treatment quite anxiety provoking, and then they improve. And the same with people's mood. Often they are quite low in mood, but over time their mood is improving, and our outcomes are as good from our groups as some of the one-to-one therapies that are offered through Talking Therapies service. So we're positive about that, but we're also positive about the feedback we get from patients, the sort of narrative feedback about how patients find the service in terms of transforming their lives, engaging in other things, new hobbies, new activities, often volunteering or going back to work. And also patients often identify other things they want to work on. So we do have, because they've been often immobile for quite a long time, people are saying, I'm worried about my weight. So we're often engaging them in other services that are on offer for weight management and things, and they find that really helpful, that we don't just look at this thing but actually look at the other effects of being immobilised for a while in terms of gaining weight and the impact on self-esteem and people's mood. So we then can refer them into other services around weight management things if that's what they want. So we connect with other services in a seamless way.
Anything published?
We have a paper that's been published on one aspect of our work, which is the compassion focused therapy group, and that's been really successful with some of our patients, and that's been published in a journal as a very innovative project that is one of the first nationally that have used this protocol for compassion-focused therapy.
I have to say, listening to that, it sounds that you and your team have had a really big impact on the health of Cumbria. And thank you very much. I mean, that's a marvellous thing.
Yeah.
I think when it just about finished, we usually like to end with a bit of a joke. But to be honest, all the jokes we know about doctors are unrepeatable. But Peter had a friend who, when he was recovering from his heart attack, he was having cardiac rehabilitation, which I know you're involved in, wrote this little haiku that we thought we might finish with today. It goes like this. It's called After the Heart Attack. No smoking, no drink, no sex, nothing sweet. I might just die of boredom.
Elspeth, thanks so much for giving
Yes,
up your
thank
time. It's been absolutely fascinating listening to you, and I really can't thank you enough. It's great.
Yes, thanks so much. It's been lovely to see you again and to listen to you talk about the great work you're doing. Thank you.
Thank you.